going back into the literature, you're never the first person that's thought of this stuff. Why do these patients have to be sedated? We're technologists. How can we make this service more technology-driven and more scalable to bring this service to more patients who need it?
Well, Ryan, thank you so much for joining me on the podcast. I'm so excited to talk to you today.
Thank you. Thank you for having me, David. It's a real honor.
Yeah, of course. You have such an interesting journey and you have done so many things that it's hard to keep track of sometimes. And I would love to know, as you reflect on what you've done so far, where does this story start in your eyes?
Well, it really starts in medical school for me. I was a chemical engineer before going into medical school, and I had a mentor in med school who was a critical care doctor in Toronto, and he had trained at Stanford. And I was telling him about my desire to have some intersection of engineering and medicine in my career. And he said, you have to go to Stanford. Like, there's no other place that you should be. And so, sure enough, interviewed there, was fortunate to be accepted into the Pulmonary and Critical Care Fellowship, and then started to look around and see, what is out there in terms of this intersection of engineering and medicine. And I think that's one of the really beautiful things and unique things about Stanford is that you can go to the faculty directory, you find somebody that's doing something interesting, you send them an email, and you're having a coffee the next day. And so I did that, talked to a lot of basic science labs. I realized that was going to be a longer trajectory from real patient impact. And I was talking to our clinical chief, Steve Ruas, who has also been a great mentor and friend. And he said, you need to talk to Paul Yock. He's got this program called Biodesign, and I think that would be a really nice fit for what you want to do. So I met with Paul, and again, I was fortunate enough to be accepted into the fellowship, and that fundamentally changed my career direction from thinking I was going to go back to Toronto and be a practicing clinician to what I do today, which is integrating the engineering and the medicine into this health tech world that we both live in.
Wow, what a story! And Steve is such a fantastic master clinician and just a wonderful person to talk to. I'm curious, when you were starting that process and starting to get that itch, were you seeing problems that you wanted to solve, or was this more of a general world of innovation that you were just excited to dive into?
I think the main issues that I was interested in were critical care related. So how could we provide oxygenation to patients without ventilation, artificial organs, things like that? I came down to Stanford with the idea that would be really interesting to develop, both from a life support point of view, but also from an organ replacement point of view. But other than that, it was more of the general kind of innovation context.
And you mentioned fairly early in the process, I guess I'll call out a bias that I think many of us have in the innovation space, which is that science projects, or the phrase science project, is almost like a derogatory word in innovation, because many of us use that as code for thing that you would love to be developed, but could take years, decades, or longer. At what point did you start to realize that you were going to want to narrow your focus from extra organ systems and brand new ways to oxygenate the body to these more discrete areas that you focused on?
I think that a lot of it was just going through the biodesign process, but in terms of shifting from that kind of organ replacement idea, I did, in meeting with several folks, we realized that was going to be a very long road, a very rewarding one for people that are in more of a basic science track, but it was a basic science track at the end of the day. In many of the folks that I was speaking with that were looking at how to, create artificial organs and tissue engineering and things like that. So that was why once I learned about the biodesign program and the fact that there is an opportunity, it's still a very long road, as we both know. But that idea of being able to translate into the bench to bedside concept in a reasonable time horizon was really appealing.
So take me to the biodesign year, because of the many things that I'd love to explore with you today, two were companies that you started right out of and maybe even during that biodesign year. So maybe we could start with Awair, and if you could tell me a little bit about the genesis of how that came to be.
Our focus area was intensive care, and we were doing a bunch of work in the ICU. And it's really interesting. It's always been kind of in the back of my mind that when somebody is put on a ventilator, they go from being awake to being sedated, and people just kind of accept that that happens. Why do these patients have to be sedated? And then that leads to all of these complications in the ICU, the blood clots, the myopathy, the pneumonias. All of these things are highly related, not entirely, but highly related to the fact that these individuals are sedated. Biodesign was actually really interesting because it was a rare opportunity to not be in the thick of providing critical care where your mind is solely on patient care, to having the time to think about these things. And the insight that we had was that having a tube in your trachea is not comfortable, and that is a primary driver of the need for sedation in the ICU. And we then were doing some work in the bronchoscopy suite and looking at, well, that's also a tube going down into the trachea, and we're able to do that with relatively light sedation, depending on the procedure type. And our insight was that there's a large topicalization process of putting a topical anesthetic into the airway to make the passage of that tube more comfortable. So that was our initial insight: is there a way that we could provide local anesthesia to the upper airway to reduce the discomfort from the endotracheal tube and therefore reduce the need for systemic sedation? And, sure enough, which is always fun to do, going back into the literature, you're never the first person that's thought of this stuff, right? So we sure enough found two different anesthesiologists that one had developed this tube where you could spray lidocaine every hour, and they were able to show that sedation requirements went way down. We actually managed to get a hold of this anesthesiologist in the UK and had a conversation with him about it. And then there was another study where people coming out from maxillofacial surgery who needed to be intubated post-procedure had a nerve block done prior to leaving the OR with a longer-acting anesthetic. And, they were basically wide awake. So we had these small studies, but they were validating enough for us to say, there's an insight, and then there's also some evidence that this actually is a key driver of sedation. And if you reduce that discomfort, then you can potentially have a big impact. So that was kind of the genesis of Awair. And, we developed this bifurcated catheter that drips lidocaine to very specific parts of the upper airway to create almost a regional effect of anesthesia. And, prototyped it, and then eventually licensed that to Cook Medical. But it was one of the things for me that, it's one of these things in medicine where it's just, we do things just because we've always done them that way. And it's sometimes, those are sometimes the really interesting opportunities that present themselves.
You touched on something that I think is a challenge for so many experts in their areas of practice, which is that the deeper we go, the more we have blinders sometimes that we don't even recognize in order to kind of narrow our focus and go deep. And this problem that you mentioned, this discomfort with the breathing tube, it certainly happens in the pulmonary world. It happens in the surgical ICU, where we have young folks who end up getting a tracheostomy, a surgical airway, because it's so difficult to wean them from the vent and to get proper sedation. Were there moments that struck you or Rush, a non-physician, your co-founder, that really drove this need to the forefront? Or is this something that had been on your bucket list for a while?
It hadn't been on the bucket list, but that was one of the other insights we had, was exactly the trach patient. Why is the trach patient wide awake, but the endotracheally intubated patient is not? It rose to the top because of the cost of these complications. And by cost, I mean the human cost of people who are coming out of the ICU. And we don't see that. We see their ICU stay, and then they get transferred to a general medical service. But what we don't see is the multiple months of recovery that comes from being in the ICU, and the kind of issues of ICU survivorship, which are in many ways driven by sedation. And we certainly do see in the ICU the complications that directly arise and are directly associated with sedation. There's multiple guidelines within the critical care community that say use as little sedation as possible. So as we were thinking about, what is all of these needs that we were looking at, the 200 plus needs and opportunities that we evaluated, this one rose to the very top because of that human cost. And then on the financial side, there's this statistic that ICU care occupies 1% of the US GDP. It's actually a little bit less than that, but it is a massive amount of spend that is largely, or at least in part, driven by the side effects and consequences of what we have to do to sustain life.
Wow. Well, Ryan, there's so much to unpack about the journey with Awair, but I'm wondering if we can put that on pause for a second, and talk about the additional company that you started during Biodesign and kind of the core human story at the center of it. Tell me a little bit about what drove the genesis of Vynca.
Vynca was also originated in the ICU, and we were seeing people that were coming in, being admitted, were typically in their 80s or 90s, had a existing life-limiting illness, whether it was cancer or dementia or otherwise, and they ended up in the ICU on a ventilator. And we knew that, looking at the statistics and the literature, that most people at the end of life prefer not to be in an ICU. They prefer to be home, surrounded by their loved ones, and comfortable. And the exact opposite was happening time and time again. And one of our other co-founders that Rush and I met, Dr. Alan Nemeth, who was a pulmonologist at the time, a pulmonologist at PAMF, which is the medical clinic right across the street, a different system than Stanford. And then he did his ICU work at Stanford. And he told us this story of having just completed a do not resuscitate form, something called a PULSed form, which is basically a DNR plus form. He had just completed that form for a patient on Friday, walked in to the Stanford ICU on Monday, and this person was on a ventilator, which was directly against their wishes. So this brought us onto the topic of advanced care planning and how do people talk about their wishes? How do people have those conversations? And then how are they codified in a way that can make them universally accessible? And as we dug into it, we realized that there were a whole host of issues, from people not wanting to have the conversation, clinicians either not feeling comfortable or not having the time to have the dialogues, often something like an advanced directive document ending up in a safe deposit box, and often that discussion happening with a lawyer in largely a non-medical context. And then the accessibility piece, if you had a document that was completed by a clinician at one healthcare facility, especially at the time, interoperability has certainly come a long way since then. There was really not a great way to get that information widely disseminated. And in particular, because these were, scanned paper forms and so on. So the initial idea coined by Dr. Alan Nemeth was, wouldn't it be nice to have a codestatus.com? And if you had a patient come into the emergency room, you could go to codestatus.com, type in their name, and get their most up-to-date advanced care planning information. Wouldn't that be great? And that was the original kind of seed of a concept that then became Vynca, which is originally was an advanced care planning solution that allows clinicians to have dialogues with their patients to create a signed medical order document like a do not resuscitate or POLST form. And we developed some patent issued e-signature technology to be able to do that in a completely digital workflow. And then we centralize these documents and develop some sophisticated patient matching technology so that if there was a document completed at one facility and the person showed up at another, that information would be pulled down. And we're very attentive to workflow and managed to get a integration with Epic for one-click access to the software. And our first pilot customer was Oregon Health and Science University, which is at the forefront of this POLST or physician order for life-sustaining treatment framework. And they were great supporters of ours and supported our Epic integration, supported us in the development and launch of the product.
Ryan, this is so complicated, and even hearing the beginning of the story in retrospect, it is intimidating to me to imagine how to go about tackling that problem. And even, I think you said DNR.com was the dream. Was that what? Do not resuscitate.com. I mean, even codestatus.com, if that had been the original embodiment itself, it seems so complicated to wrestle all the loose noodles together. How did you decide that this was how you're going to get into the problem and make this your foothold?
It's a great question, and I think, to be fair, a lot of the complexities were certainly not addressed in the first iteration of the solution. And we focused first on, can we complete a document in a valid way? So we looked at these forms because people don't necessarily fill them out all the time. There was at least a 20 to 30% error rate just on how the documents were completed. So we said, well, that's one big problem that we can fix. That's low-hanging fruit that we can fix. The second aspect was, how can we make this a structured piece of data rather than a PDF? And that leads to much more efficiencies for a lot of reasons. So that was low-hanging fruit. And then the third was the interoperability piece, because that was really the core of the need that we were seeing. It was not only the fact that people had the conversations, but they weren't accessible at the time of the emergency. But you're absolutely right. It's an incredibly complex space, and it addressed what we perceived as some of the key things to make it much better. And that was part of our thinking too, is, this is a big problem to solve, and we're not going to get to a 100% solution on day one. So let's think about what are the key things that we can solve today. And at least if we can improve this by 30, 40, 50%, I mean, that's still pretty good. That was how we started. But you're absolutely right. It's a very complex space to dive into, and remains so today.
You mentioned that OHSU was your first customer, and what a just wonderful alignment that was with their culture and priorities. I recognize that this doesn't just kind of happen. There's no universe where potential clients sort of look to see who's working on what and come to you. How did that work, and how has it worked as you've grown along the way to start getting new hospitals to be your customer? What's that like?
Well, I think the early connection to OHSU just came from getting out there to the community. So we started in California, and we started to go to some local coalition meetings that were focused on advanced care planning and on serious illness, palliative care, and so on. And that was how we learned about the space, how we learned that OHSU was a real leader in the space. And then we happened to meet the leader at OHSU over the Pulse program, and told her about what we were working on, and they had actually been trying to do something similar, but with kind of a PDF completion tool. They were starting to think about, like, how do we do this? So we showed them a little prototype that we'd built, and they were really engaged in moving forward.
Was there a point as you started slowly gathering momentum that you and Rush and John really said, you know what, this is going to work. This has legs. Did you ever feel that way?
I think the thing that gave us the early validation was going from OHSU to, our second health system, and then our third health system. And what I would say was the greatest validation was partnering with Sutter Health across their entire enterprise to implement the software. So that was what that sort of ongoing validation of the need, and people who were, at first we had OHSU, and then had a smaller hospital, and then with Sutter coming on board, that was really the first major implementation that we got done, and that was the validation to keep moving forward.
Wow, that's so exciting. I'd love to learn about how you started to expand what Vynca does, and now you are out of the hospital and involved in a form of care in patients' homes. What did that look like?
Well, I think there were a few drivers of expanding the focus of Vynca. The first was that with respect to advanced care planning itself and selling into health systems to solve the problem, we recognized a few things that made continuing along that arc in a solo fashion to not be a sustainable pathway. One was that there is a general trend toward moving away from any kind of point solution. And this is fundamentally a clinical workflow solution, a point solution that solves a very important problem, but it's still a point solution. What we learned from working with the IT departments is that every single point solution, every Vynca that they've got to partner with, they have to maintain their interfaces. There's costs on their end, and that is real. And the larger EHRs are, of course, working simultaneously to build out all of these custom workflows within their own systems, so that their value proposition to the customer is, you don't need any more point solutions. You can just partner with us. You've got one vendor, and you can forget about all these other point solutions because we're doing it. And of course, it's never as elegant a solution, is never as effective a solution, but there's that definite headwind in selling technologies into to health systems. I think the second thing is that there is for this on the point solution side, there also is a range of fee that a hospital is willing to pay for any kind of point solution. And then the third aspect I would say is that every hospital sale is this important for patients component, and we very clearly tick that box, but there's also a financial ROI component. And if you actually look at the economics, as terrible as it is to say, there actually is not much of a financial incentives for hospitals to solve this problem. Certainly from a clinical need, it's there, but in aggregate, when they look at the 1,000 different issues that they have to tackle, it was hard beyond our first several health systems to continue to work through it. They're very lengthy. It's a true enterprise technology sale, so very lengthy sales process, multiple stakeholders, and so on. So that was sort of there's some issue with scaling the advanced care planning. But on the other hand, we also realize that there are much greater needs than just advanced care planning for individuals facing serious illness. And even if they had an advanced care plan done, it doesn't mean that they're going to get access to the care that they truly need to support them through a serious illness. And that led us to look into palliative care, which is a specialty and domain of medicine that is focused on helping people to manage through serious illness while there are still active treatments going on. And it's upstream of hospice. At hospice, of course, you're giving up basically any active treatments for the underlying condition, and the focus is much more on the symptoms that an individual has. And palliative care is something that is enormously important for patients, for families, and there is a strong set of data to show that if you can get people the care that they need in their home, if you can manage their symptoms, if you can coordinate their care, you can avoid them ending up in the hospital. Because one can imagine if somebody has uncontrolled cancer pain at 3 a.m, they're definitely going to the hospital. But if they have a care team that's specifically focused on their symptom management and gets ahead of that, that emergency room visit and that hospitalization is not going to happen. And there's strong data to support that. That was kind of taking a step back and rebiodesigning and saying, where's the broader scope of needs? Do we need to rescope here? Then it was, well, how do we implement this? We think that there's an opportunity here. We ended up acquiring a medical group that was doing palliative care, and they were doing it largely with virtual tools, which we liked because it was the driver for them to do this was to serve rural populations and people that were 50 miles from the nearest clinic and otherwise who have no access to this kind of specialty care. They were able to do that in a virtual context. So we liked that about them. And the other thing that we liked was that they had managed to structure payment paradigms with health plans to provide these services. And the challenge historically with palliative care is that it's typically a fee-for-service, physician or provider-driven activity. But to really deliver palliative care well, you need to have a true multidisciplinary team. You need nurses, care coordinators, social workers, and so on. And that's very hard to actually implement when it's the nurse practitioner or physician E&M code that's doing that. We ended up acquiring the organization that allowed us to have these partnerships off the shelf with the health plans to deliver this kind of care. Then we consider ourselves a technology company at Vynca, and the goal was really at the time to say, well, we're technologists. How can we make this service, which is already being delivered largely virtually, but how can we make this service more technology driven and more scalable to bring this service to more patients who need it?
Such a beautiful natural extension of a point in life when people can really use better, more coordinated care. So, Ryan, one of the arcs that I hear when you share these stories is this focus on people and some of their most core vulnerable points in life. Awair, really targets the experience of someone who is kind of all alone on the ventilator and experiencing this potentially really scary moment. I think of that being very similar to someone who may be having a cardiac arrest and can't necessarily advocate for themselves. And you have built these technologies that target moments in life in a way that are very different from a heat sealing device that's used for a particular step in the operating room or something like that. When I think about what you're doing now with Kin, it really feels like it's part of that same flavor, targeting people who are vulnerable, who are in need, who might be struggling to navigate a system. And I'm wondering if that's something that you have thought about consciously, or if that's just sort of flowed as a natural extension.
I mean, I think that is the reality of the ICU is, you're seeing extremely vulnerable people in very serious situations, and you're also seeing their families and the impact it's having on them. The ICU is a place where you see that part of life, and you see the humanity of that, and that's, I think, where we were spending our time. And one thing has led to another, but it certainly is a very rich place to innovate in the sense of the level of need, and I would say the level of human need that is there. It is a very complex part of the universe to be innovating in, but it definitely from an impact point of view is there. And certainly with Kin now, there is a lot of crossover in terms of the types of individuals that we're taking care of in terms of the population. But the insight with Kin was actually from the adult child, and going to a professional event or a social event, not being able to leave that event without having a conversation with somebody about the challenges they were facing with their parents, and how much of a challenge that was for them personally while managing their own career, their own family, and of course wanting the best for their parent, and seeing the struggles that they were facing as they got older.
One of my colleagues used the expression with me that watching her parents age has been the biggest unexpected shock of becoming an adult, being an adult. And I really hear that in how you describe it too.
It absolutely is, and it's something that I think it's a real transition from that kind of caretaker role that the adult child reversal that happens, and it happens slowly. It can happen quickly, but it is a big transition.
Could you lay out what you are building with Kin and what the fully realized vision looks like?
Well, Kin is what is called in, I suppose, industry terms, a geriatric care management and clinical advisory service. So what we're effectively doing, and probably the easiest way to say it, is that we are the expert adult daughter, because most of the time it's the daughter that is taking care of the aging parent, that understands what the issues are, is an expert in the field, and is able to be text messaging and calling pharmacies and going to medical visits. So I've heard the term for geriatric care management as the adult daughter on steroids, that families engage to support them through this. We engage people typically at three different moments. One is what we call proactive management. So that's a situation where the parent is relatively independent, doing well, but perhaps they've been recently widowed. Perhaps they're struggling a little bit with independence. They've got multiple medical specialists. So everything's okay, but there's a desire to have just an extra set of eyes on things. And often the son or daughter will be geographically far. That's the first use case, the first way that we get referrals. The second is around crisis navigation. So either a new serious diagnosis or an unexpected hospitalization, a surgery, otherwise. And then the third is ongoing support. And that's typically after something has happened that has changed things, whether that's a stroke, a dementia diagnosis, or otherwise, but where the parent needs ongoing support to maintain their overall health independence, whether that's in the form of caregiving, whether that's in the form of moving locations into a senior living community or otherwise. But those are the three situations where we're engaged. And then our services are clinical advisory services. So we help people to understand their diagnoses. We take the medical jargon and turn it into plain English. We review their situation and make sure that they're getting the standard of care. And if not, we get them connected to the right specialist and or service their advocate at the medical visits. We will go to the medical visits with the client. The second aspect is around care coordination. So we manage all of the appointment scheduling, follow-ups. We make sure the medications get there on time, any supplies. We'll even get into fixing internet passwords and things like that come up.
Wow.
And then home safety, things like that. And then the third is around curating any kind of resource that's needed for the individual. And this is a whole person approach. So every one of our clients has a physical therapist. It is a mandatory thing, whether it's a Medicare covered physical therapist or a private physical therapist. Exercise is just so important to maintain health and independence and longevity. But other things like private caregiving, nursing, otherwise. So our job is to curate the best options for the family, give them those options, and then to support in a coordinating role between all of those service providers as they're brought online.
Wow. What an incredible service. I think a lot about Paul Graham, founder of Y Combinator, among many things, who's spoken about doing things that don't scale, doing them very well in the beginning as a way to connect with your audience, get insights, all sorts of stuff. Hearing about this from you, it sounds like the ultimate challenge in elbow grease for one person to do alone. And I'm so curious how you are starting to scale this and what that looks like going forward.
It's a really good question. So we've kind of deliberately chosen, this is a concierge service. So we've deliberately chosen a very bespoke model of care where we're serving relatively few families for each physician advisor and concierge care manager. We're much more akin to a concierge medical practice where they may be managing 50 families. Each doctor has 50 families. And those models are, I think, paradoxically can scale. So if you look at some of these practices that have emerged over the last several years in the concierge primary care space, they keep that 50 family per doc approach, but then they're opening practices, multiple times a year in new markets, or in some of the markets where there's a lot of capacity, they may have 6 or 7 locations within Manhattan. So I think there is a way to keep that level of service and that bespoke and highly individualized nature of the service and still scale it in that way. And we're seeing some great examples of that. I think we're still early, to your point, and I think there definitely is some really interesting technology automation opportunity that I see that could help to bring the solution to a wider range of individuals at a lower price point. Right now, my goal is to be, first of all, providing exceptional service to our clients, but secondly, learning where those opportunities are to, on the back end of things, make our processes more efficient. This, to me, is a really unique time in healthcare where the traditional paradigm of the payer being different from the end user is actively breaking. The cost of care has been pushed to such an extent to the end user at this point that it's finally driving the ability of the healthcare consumer to choose their healthcare experience. And for people that want to pay for an experience that is exceptional, they're finally able to do that. And we see that from the $100 a year One Medical membership, where you go on the app, you renew your prescriptions, you can do instant video visit, $100 a year. That's a consumer saying, I'm willing to pay for this, all the way to the concierge multi-specialty clinics where you're spending $60,000 a year per person. There's everywhere in between. And my belief is that now is the time in healthcare where we have this great opportunity to finally provide exceptional care without that fundamental disintermediation between the payer and the end user.
Ryan, I'd love to know how you think about a future with Canon. If we just make a scenario here where it is financially successful beyond any need that it would require to grow, can you kind of imagine with me what that would look like if this were fully realized and then some?
To me, it's about the access piece, and as I said, I think there's a few different ways that this could go. So I don't have a fully realized vision, but I think there's 2 different potential ways. The first is to continue to grow what we'll call the concierge segment in the manner that I described with the kind of 50 family approach. But I do think that there's a way to democratize this, if you will, to say that if we are able to reduce our costs of providing the services to the point where we're able to significantly deliver an excellent product at a more accessible price point, this could open up the market to a far wider range of individuals to use our service. So I think there's a really I think both of those are feasible, and maybe it's a combination of both, having a concierge tier and then a more accessible tier. But right now, again, it's about really delighting the clients and taking those learnings to see how we can make this more of a scalable and accessible type of solution.
Thanks for walking me through that. I'm wondering about the human experience with a fully realized kin. And you said something earlier that really resonated with me about helping clients log into the website. And I'm thinking of so many clients who might have internet passwords, website passwords scribbled down on a piece of paper somewhere in the room, who might not know how to click to download an attachment, who might struggle to even download an app, let alone be able to get the touch screen to register their their fingerprints in the right place. And that to me is more to come as technology sort of laps many of our most senior citizens who need its benefits. And I'm wondering what the future looks like with a fully realized kin for these people, what the future looks like for these patients.
Yeah, it's a really great question, and it's an area where, I personally learned a lot, which has been a really, really amazing part of the journey. So I think there's a few components. The first is that there is definitely a need to have a boots on the ground presence. So at this point in time, there absolutely is a need to go into the home, to be there, to be present, to be understanding what's going on, and to be doing things like, oh, well, let's get this out of do not disturb mode so that your daughter can reach you again. So those things are still needed. But I think there actually is a surprising amount of technology that is very accessible to people. I can give you one example. One of our clients has both a significant hearing loss and vision loss, but she's able to interact with her Alexa very easily. She can turn music on, listen to music, and she can make phone calls from it and otherwise. So that's an example of a technology where once it's set up, it basically is on, for the most part, going to be on autopilot, and gives this individual who has these impairments the ability to communicate with her loved ones, the ability to have listen to music or whatever the case may be. There also is a lot of technology that is emerging around home safety in non-invasive ways that people can be monitored in their home, for example, fall detection and other things like that. And I guess the final way is that within an iPad or an iPhone or otherwise, there are some ways that you can kind of set things up to be lower risk, to have these kinds of events. So I've actually been really pleasantly surprised by the level of technology engagement that our clients have, and that's often with their own existing technology. And where we see opportunities to implement more, we'll make those recommendations to get, for example, an iPad if vision is an issue or otherwise. But I'm actually fairly bullish on the concept that you can bring a lot of technology around people who you may think may not be able to engage with it quite as well. But in fact, the state of things today is such that it really is a wonderful addition to their lives, and it's a wonderful way for them to remain engaged and happy and in touch. So it's been a really interesting learning experience from that point of view.
Ryan, you're at a point in your life where I'm sure folks must come to you all the time for advice and to ask you how to get started. How do you advise someone who maybe has the beginnings of an idea, or maybe does not even have an idea yet, but they want to be able to build a career in innovation as an inventor, and are struggling to figure out what those first steps look like for them?
Well, as a student, perpetual student of biodesign, much of my advice is around the needs-driven approach to innovation, of course. And I always encourage people to engage in that process through either the fellowship or through some of the online resources or otherwise. Aside from that, I think that there's a few things that I guess I've personally seen in starting Kin, which is that there's so much that you can do with, Chat GPT or Claude or Gemini that allows you to do this innovation process so efficiently. If you follow, for example, the biodesign process, you can go back and forth and get light years ahead of when I was a fellow, and iterate so much more rapidly to get there. And even at the point of company formation, the efficiencies are incredible to see how things that would have cost thousands of dollars 10 years ago are now basically free. And the barriers to entrepreneurship just over the last year or two have come down so dramatically, so dramatically. So then it's not so much about, the starting the company and, doing all of these things that go to market. Now that's very, very easy. The hard part goes back to what is the need we're solving? Who is the market? Who are the stakeholders? And, how are we going to solve a problem for this? I think it's a really exciting time to be an innovator. And if you're willing to engage in those things, to to get that education on the fly, it's really incredible. It's just night and day from when we started Awair and Vynca to starting Kin now. It's the barrier to entry is just so dramatically lower.
I love how you put that about some things that might cost thousands of dollars. I wish I could remember the name, but I came across a tool recently that creates scientific illustrations for research papers. A postdoc working on a PhD in some sort of basic science arena made it solving her own pain point. And just the cost of a single medical illustration can be, like you said, can be thousands. And so you're hitting on something that feels very profound in terms of being light years ahead of the level of efficiencies. Ryan, this has been such a special conversation. And for people who would like to learn more about you and about what you're working on, where can people go?
Our website is kinconcierge.com. And thank you so much for having me today, David. It was a real pleasure and honor to be here.
This has been such a treat. Thank you so much.
Thank you.